all of us together around the table to ensure that we become a model for health security response. This meeting has started, and I think it should not end at just the recommendations. I think the next meeting, if it's for East Africa, should tell us what has really been picked up in the countries from what we are discussing. What have we seen in ensuring that health security is moving forward in East Africa? What is the collaboration? Do we now have a platform on which we can stand and say we are talking one language in East Africa? Our colleagues in Africa CDC are here. We have a hub here, we have the private sector, we have colleagues from Nebraska who are here. Can we have a side show where we really have to concretize the 4 things that we would want our governments to do in order to ensure that health security is guaranteed? There are many things we want the government to do, but can we say if they do these 4 things, that we will be on the right path when we meet next year to talk about the progress we are making in ensuring that East Africa is a model for health security. So those will be my parting words.
Thank you so much, sir. Please, a round of applause to Dr. Francis Kasolo, who is the World Health Organization Director to the AU Liaison Office. We kept that slide there, I think being a very, very critical one on the key steps and his thoughts, of course, as an expert in this. Allow me now to transition to the panel. And sorry, I think there were a few questions. I saw some few hands raised. So I'll give you an opportunity during the Q&A session in the next panel. This one will be looking at One Health, linking human, animal, and environmental health for a secure future. Please let me invite Eric on stage, who will be our moderator from ILRI, that's the International Livestock Research Institute. He'll be joined by James from the University of Nebraska, and we'll be having a virtual representation from Dr. Mohamed Elduma, who's the Health and Social Development expert from IGAD, and Dr. Martin Mushangi from AMREF. This session will take 30 minutes. Thank you, ladies and gentlemen. Eric, it's over to you.
Thank you. Do we have any online participation?
Yes, please. We have Dr. Mohamed Elduma on standby.
Great. Welcome. Okay. Thank you, everyone, and thank you to the organizers, first of all, for inviting me and also for putting this session in the agenda. I'll say a few words and then I will give an opportunity to the panelists to introduce themselves. Today, well, first, me, I'm Eric Favre. I'm from the International Livestock Research Institute, which is based in Nairobi, here in Kenya, and I'm a professor of veterinary infectious diseases, and it's great to be a sort of semi-animal infectious disease person in this audience of very public health focused people. Sorry. Thank you. So One Health, which we're discussing in this short panel today, is really, to me, a way of thinking. It's a way of integrating the way we think about human health, about animal health, and when I say animal, I include livestock and wildlife and any other non-human animals in that, and of integrating environmental health in the way that we think. It's been very much a focus of academic discourse and academic work over many years, but in the last, I would say, 5 to 8 years, it's really been an approach that has been taken up by international organizations that guide the international agenda. And in this, the World Health Organization, the Food and Agriculture Organization, UNEP, the United Nations Environmental Programme, and WOA, the World Organization for Animal Health, form what's called the quadripartite, which really create a kind of international governance structure, if you like, around One Health. And they, as organizations, and the people who support them, are working together to build integrated approaches, a One Health workforce, and many joint outputs. And many organizations have followed suit and have taken the One Health approach into the way that they think and operate. So for example, ILRI, where I'm based, has integrated One Health thinking across its programs and brings together considerations of animals, humans, and the environment in almost everything that it does now. But in the public sector, for example, in Kenya, in the Ministry of Health, more broadly in Africa CDC, as we already heard, in WHO, and in many organizations and in all of the countries represented here, One Health has started to take a kind of key part of the health agenda. So that's really where I wanted to start. And with that, I want each panelist to please take a microphone and please introduce themselves and maybe say a little bit about why One Health is relevant to the work that you do in your organization. Thank you.
Thank you. Good morning. Hello again, everyone. I'm James Lawler. I'm from the Global Center for Health Security at the University of Nebraska Medical Center. I'm a professor of infectious diseases. I'm a last-minute substitution here on this panel. I was subbed in extra time, but very happy to be here and to be able to speak with you. So I have spent a good portion of my career investigating emerging infectious diseases and pandemic threats, and obviously most of the pandemic and severe emerging infectious disease threats are zoonotic and reflect that interface between human and animal health that Eric was discussing. I think that my perspective on One Health has been that it is a great idea and a great philosophy that sometimes we have difficulty translating into action. And I think that we in the US have a great example of that going on right now with the H5N1 highly pathogenic avian influenza outbreak that's happening in the US in dairy cattle. And it shows where the divisions and difficulties between different disciplines in animal health and human health and in the industrial and economic factors that come into that, where those divides still really impede our ability to work as a unified response in these types of emergencies. And I hope that we are able to break some of those divisions down so that we're able to provide a more cohesive and unified response, but there's still a number of barriers that exist, and hopefully those are things that we can discuss a little more today.
Good morning. My name is Dr. Moshangi Martin, and I work for AMREF Health Africa as the Director for Population Health and Environment. Above all, I'm a lecturer, I'm a teacher, and I'm a researcher. Right now, I'm leading an initiative that is seeking to establish research hubs on climate change and health in 14 African countries. And in the directorate that I'm leading, we are implementing a couple of programs cross-cutting around water sanitation and hygiene, neglect and tropical diseases, climate change and health, and issues to do with the food systems and livelihood. I started interacting with the One Health the last 3 years, and what attracted me into this subject area is the realization that there can be only one health, and that is a phrase which has been said many times. But the reality is, if you look at the zoonotic diseases, 60% of the infectious diseases are zoonotic in nature. So what it means is that if our animals are not healthy, then human beings cannot be safe. And at the same time, if our ecosystem is not healthy, for example, like what is happening with climate change and health, it means we are vulnerable. So for me, One Health is not just an approach. It is the integrated model that we should be seeking to advance. And noting very well right now, we are talking about resource constraints, we are talking about intersectoral collaboration. So this is a model which offers us an opportunity to make sure that we get things right. Yeah, thank you.
Thank you. And online, please unmute yourself. Thank you. We are. Please go ahead. Thank you. So that was those were some nice introductions to the way different organizations think about this issue. And so I guess I want to challenge each of the panelists a little bit and ask whether, in your view, we still have to sell this approach. Is this something that we have to sell to everybody else, or has everybody else already bought into it? Our One Health approach is effectively these integrated ways of doing things. Are they now mainstream? And why or why not? And perhaps thinking about that in the context of your own organizations and how that kind of intersectoral working happens in your organization. We'll keep the same order. Yeah.
All right, so I'm first. I do think that there's more selling that needs to be done for the concept of One Health, and part of it, I think, is showing tangible results from One Health research and response in emergencies. There's no better selling point than results, right? So showing where public health, human health research, animal health research, environmental research, how when combined and working together, we can produce meaningful results in community health metrics. Whether it's levels of antimicrobial resistance, which I think is a great area that we need to work together on, whether it's in outbreak response, which again, we have the ability to show improved outcomes when we work together, or whether it's in baseline health statistics for people and animals. I think there's tremendous opportunity, but I think that's on us to show and to show demonstrably with data that One Health actually does make a difference. And that's where I think we have sometimes fallen short in going that last couple of steps. I think for many of us, the concept is obvious, right? And we don't feel that we need to explain or justify to ourselves. But I think for many outside, especially many who control purse strings, we do need to demonstrate to them definitively that the concept in action can work and make an impact.
Thank you. Martin.
Yeah, sure. I would argue this in two ways. From the policy perspective, the approach is on the supply side. You know, the quadripartite came together and they are really pushing the One Health approach. But when you go to the countries and you ask the policymakers whether they are aware about One Health, whether they are investing in One Health, now that's a problem. When you go to the technical teams, then you realize zoonotic disease units together with the mainstream ministries of health, they understand One Health. It is on the demand side. So we need to evaluate the actions that need to make sure that policymakers are actually brought on board so that they start understanding the value proposition of One Health, they start investing and actually championing about it. Yeah, all the meetings which I've attended, you realize that the technical teams are actually present, very good arguments, very clear cases, but then you really find top-level government acrons speaking to the same subject. So I would argue that, yes, it's something that we need to keep on pushing, but we need to be strategic enough to ensure that the policymakers actually buy into it. Yeah.
Thank you. Elduma?
policymaker. But I think doing examples that can be taken, I think it will be very important. So we brought Africa CDC, US CDC, AFNet, countries, and WHO in this integration of One Health into FALTI. I think we are, one of the other things we integrate also gender, and I think gender is very important to One Health, where domestic animal handling and fetching water and all this interaction with One Health, I think is coming through the females and others. We are developing a framework to improve the implementation of One Health, and I think that would be very important so that in a practical way, all countries, they have strategies and action, but the implementation is issue. With the support of the World Bank, we will support performance of veterinary service evaluation. We are just talking about bringing other sectors all this, but I think supporting this integration of animal health, if I can say animal health and environment and into human health, we need to take steps further. We are supporting some bridging workshop where to bring a result of the performance of the veterinary service with the result of the GIE on IHR core capacity. And I think in our plan also within the pandemic fund to support integrated laboratory. We know if from the start people think about discovering the relationship between both human and animals, we might have response earlier than planned. We are doing also strategic risk assessment across border, where we are bringing animal and climate health experts and developing a contingency plan to some selected cross-border area. I think by this, we are trying to move from policy or theory to practice to implement some of those animal One Health issues. Thank you so much.
So obviously climate change is affecting epidemiology of diseases that we worry about in One Health, and affecting all three corners of the epidemiological triangle, right? The host, the pathogen, and the environment. And that's going to necessitate our changing along with it and changing our strategies and our approaches for disease characterization, surveillance, and control. In many ways, I think it is a challenge to us to build more reliable systems, right? Systems that can adapt to change, respond rapidly, and still function as they're needed to. And that should not be something really that's just driven by climate change. There are many other factors that are impacting disease transmission and epidemiology and are contributing to the growing pace of emerging disease outbreaks and the impact that they have. And so I think it's more of a challenge and a call to us to make sure that what we're doing and the systems that we're building are not only resilient, because resiliency implies that there is some strain that deforms the system and then the system can come back into operation, but in that period of time there's disruption. Reliability in industrial terms, where your system can continue to function and do the necessary things it's supposed to do despite all of these external stressors is really what we should be focused on, making our systems more reliable in the face of increasing demands and change. So for anybody who's read Nicholas Taleb, who wrote The Black Swan, which is a pretty famous book describing these unpredictable events, he also wrote a great book called Anti-Fragile, and he talks about building systems that are the opposite of fragile, which is, I think, something we need to focus on in public health and health security. And so that, that type of anti-fragile system can adapt to climate change. It can adapt to changes in economic and political factors. It can respond to demographic changes that are occurring. And those are the types of approaches I think we need to focus on, especially in One Health.
Yeah, sure. Just to take on what James has spoken about, there's no question that climate change is one of the main disruptors of our health. And we expect that disruption to worsen in time. And this is because the projections are quite clear that global warming is continuing. Worse off, we have seen some of the policy shifts that are actually negating the very foundation of reversing the trends. But that said, of course, climate change has very direct and indirect kind of relationship with health. The main question and what we should be inviting ourselves to do as the health sector is to now ask, what is it that we should do moving forward? And I think just referring from the WHO guidance, it's very clear that we need to move forward and implement imperatives that are going to ensure that we have climate-resilient health systems. And what does that one mean? It means that moving forward, we need very authentic research and evidence that can help us to understand the pain points, where we need to invest more, what we need to do at the localized level, at the national level, regional, and global level. That needs to come out very clearly. And I'm happy to say that the initiatives like the one which I spoke about, the one which I'm leading around forming research hubs that I'm going to dive deep into that. So that's point number one. The second thing is that there needs to be very strong investment around early warning systems. And this should not be a duplication of what is happening right now, but it is an aggregation or upping the game in terms of appreciating climate data into the health data and using that to form a big picture that can help us to get better prepared. Then the other thing which I would want to speak to is climate change and health. There's a lot of health workforce illiteracy around that. So we need to invest seriously around building the capacity of the health workforce to understand and to move forward to implement actions that can mitigate around the issues of climate change and its impact on health and One Health in general. Then lastly, I tend to feel that when we are talking about coordination,
Thank you. Question for the MC. Are we running out of time, or do we have time for another round of questions? I know that you wanted to shorten this session.
Please go ahead, sir. I think just scanning the audience. Any questions? Okay, we'll take the 3 hands. So I'll come to you and then we can wrap up.
Thank you very much. I'm Amy Groom with Project ECHO, and to your point around health, building the capacity of healthcare workers, I wanted to mention a resource that many of you may be aware of, but if not, there are a lot of partners in this room that might be able to help scale up this initiative. The Columbia University, their Global Health Consortium group has an online course on health and climate change, and it's an online
see significant de-risking of those investments by government, because you can't quantify exactly what you will need in terms of even vaccine preparedness. If you look, for example, the COVAX facility that was supporting the development of COVID vaccines, the pandemic kind of went off when the manufacturing was ramping up. So a lot of companies had made excess vaccines that have to be paid for, but were never really used. So somehow you need this kind of government or international development de-risking of those investments. So that should be my openings.
All right, thank you for that. You've touched on it. I had a conversation on local manufacturing in what you say. So I will ask you to stew over that, and I will come back to you on local manufacturing. Okulo, from KCB, my good friend. We have various ways of financing things. Perhaps top of your head, what do you think are the more innovative ways of doing things when it comes to pandemic preparedness? Do we have any innovative ways that we can tap to or come to, especially from the mainstream commercial banking side?
Yeah, thank you very much, Dr. Theuri.
We've made a step towards averting the next pandemic.
Okay, thank you. Well, that's a good question. This is a good topic we're discussing here. Maybe what I should do is to start by introducing myself. I'm Francisco Songano. I'm a member of the council, which is the board of the Africa Public Health Foundation, and I'm also currently fulfilling the role of the interim CEO. We have offices in Nairobi. We are based in Nairobi in terms of our secretariat at the Sanlam building on the old Waiyaki Way. To contribute to the audience in terms of explaining who we are, because you can ask what is this kind of animal, where they come from. The Africa Public Health Foundation, we are born out of the initiative from Africa CDC, created by Africa CDC with the purpose of providing a partnership platform and mobilize resources for Africa CDC. This happened in November 2019. And at the beginning of 2020, as all of us know, we were hit by the COVID-19 pandemic. So the mandate which was given to us, we had to be tested right from the beginning in the first quarter of 2020. That was a baptism of fire. That's how we operated. So we had to run and set the structures and mobilize resources. Just to cut the story short, let me refer to what we did in the response to COVID-19. As you were asking whether the countries were prepared or not, we discussed before in the past 2 days, and we realized that we need better preparedness. The conference here, the purpose is what we learn from the previous experiences and how we get better prepared. But it's important to highlight the response that came from this continent. It has been stated several times that it was a lesson from the world to the whole world in terms of how we responded. And we provided that platform of mobilizing grants, mobilizing resources to help Africa CDC or to collaborate with Africa CDC. And one thing that came out of this is a good experience. I think we can build from that, is that APHF created a pooled fund specific for COVID-19, the response. There were discussions before about the multiplicity of donors, multiplicity of management of grants, and with this creation of the pooled mechanism to respond to the COVID-19 was a major success in terms of alleviating Africa CDC itself, alleviating the countries with multiple reporting, and providing a permanent flow of funds. And as a result, more than 1.8 million people were vaccinated against COVID-19 and many other activities. So this is extremely important to highlight. So let us build from there. And the other element which is important, we have the private sector here with us on the panel and in the audience. that was a good initiative from Africa CDC of creating this platform, because we are a gateway or a door through which the private sector, the philanthropy can contribute. We all know that state structures, even the African Union structures, there are strict regulations you have to abide by in order to provide funding. And the existence of this platform is critical. It proved to be crucial. Most of the resources we managed, about 40 million US dollars, they came from philanthropy, private sector, and not from the state actors. And that played that role. Even that pooled fund I'm talking about was contributed to by the philanthropy and the private sector. And now that the COVID-19 is over, we're moving beyond to expand this platform to get innovative approaches in reaching out to the private sector. So to highlight this. So it's extremely important that we build now from these lessons and we get a much more robust way of responding. So let us probably use this example, and why not think through of a possibility of getting a similar mechanism for the region in response to this conference, to provide a platform for the private sector, philanthropy, who will not be able initially to join a structured public mechanism contributed to by the states. I'll come later on the further interaction for other issues. Thank you.
Thank you. Francisco tells us he has been in class, he's written the notes, we just need to revise. So I think quite some important lessons there. Professor Kihara, now I come to you, and the conversation we are having here is how do we ensure our future against catastrophic events. It could be anything, it could be a virus outbreak, it could be a disease that comes up, it could be whatever we are discussing here. In your thoughts as a practicing clinician and having this start and end at the community, how do you think we can better ensure this future that we are talking about?
Thank you very much, Bwana Moderator, and I really want to appreciate the recognition that gender matters. And I'm going to start it without fear or favor, in the sense, financial matters begin in households. You've all talked very eloquently on the macro level. I want to move to the micro level and make us all reflect on COVID. What was really happening in that space? We had the silent pandemic in homes related to gender-based violence. We had the silent cry for lack of food and basic needs in households. Really, even that's what precipitated a lot of the gender violations happening. Essential services broke down as a result of COVID pandemic. People just didn't have money to access care. And I really want to emphasize, much as you're looking at the macro environment, you must not forget the micro environment. A lot more women together. In Kenya, we have what we call chamas. We have table banking as initiatives that really catalyze women having some buying power. Even that was broken down because it meant women were not able to congregate as they normally would, either in churches or in the community. So when we're thinking of global health security, you must remember the challenge. And the challenge even becomes more for a woman in pregnancy. In pregnancy, the fact that she also has to take care of the basic, the husband in the home and the children. Really, that suffered, I mean, I can't even mention it, the malnourishment that happened out of it, the diarrheal diseases, the other compounding health issues that come up as a result of a pandemic, existent or ongoing or even lapsing out. So I want to really focus. In fact, as I sat there, I said, the woman the woman, is one person who must be integral, and the gender lens must be integral as we think of gender-related global health security management.
All right. Just to stick with you, maybe for some 30 seconds, how do we prevent that disproportionate effect of pandemics on risk populations? How do we help them better?
How do we help them?
Finance. Yeah, using finance.
My bankers are here.
All right.
They all have initiatives that speak to women-related banking issues. But we have layers. When the bank asks for security, does the woman have it? We now bring in culture. We now bring in strength.
Okay.
So I think the banking system, whether it be global, like my World Bank friend here, or even national, when you talk about provision of resource and financing for women programs, there must be some concession, there must be some education. In fact, we used to have what we call the Growth Women Enterprise conversations. These need to come back to really strengthen how women can access funding. We're doing this through the Table Banking Initiative of the First Lady. That is really helpful. But again, I also want to marry this session with what has just passed, the One Health.
Yep.
And there was a lady who was talking towards that direction.
Speak about bonds. Bonds are issued by government, preferably for specific purposes. And I think if we wanted to think of ways of maybe of tech or some other things like that, we can issue a specific bonds for these commodities, because I find it's only in Africa where people buy cars cash. So even our governments are behaving in the same way. We only want to procure things that we have money for in the budget. So when I go to Treasury, they ask me, do we have this money in the budget to buy this equipment? And it shouldn't be that way. The government will be here in 100 years. Why don't you plan and have a bond that allows you to pay for certain things over a long period of time? So as we engage with the various players, I think we should be able to structure specific emergency bonds that are backed by state. I keep emphasizing why you need to back them by state, because if they are not state-backed, then our international financing partners will not be very interested in investing in them. If I just issue an Olayo bond, the uptake will be extremely poor in the international space. But the returns on bonds issued in Africa are extremely good right now. So they become very attractive to international pension funds and others that want to invest in them. So I think the only barrier we've had is convincing the government to specifically issue a bond that can back these kinds of investments. Thank you.
Thank you, Bernard. Okulo, still on the same, how can we curate these bonds to be responsive to the health sector? What components can we tweak? What components can we add to them so that, like we've said, when that time of an emergency or a catastrophe comes, we are able to, one, liquidate, but also usefully do so in response to our health needs? Yeah.
Okay. Thank you. But before I comment on bonds, I'd just like to speak a bit about the very important issue that my co-panelist has led on gender and ensuring that women get their rightful share of the resources in the economy. And at KCB, we distinctly recognize that there was a problem, and we have developed a program called FLAME, that is female-led enterprises, female-made and led enterprises. And through that program, we've committed to lend up to 250 billion Kenya shillings over a 5-year period. As at March last year, we had lent about 116 billion shillings to over 680,000 women who are members of this group. And to address the issue of security, we do lend up to 10 million shillings unsecured. And for the chamas, the organized table banking groups, we leverage the funding up to 10 times, up to a maximum of 250 million shillings. And this program has been probably one of the most successful products that we have in the bank. The performance is much better than many other products that we have. It's specifically led by our managing director, Mrs. Anastasia Kimtai, and every year she does a tour around the different countries, meets members of these groups, because it's not just providing funding, but it's also ensuring that we provide technical support and bring in other partners that provide entrepreneurial leadership skills. We've also inbuilt an insurance program whereby for any business that is female-led that has a minimum of 3 members, there's an insurance package that is available. So thank you very much for raising that issue. From a macro perspective, certainly the bonds are critical. In my view, there are many structures that mitigate the risks around that the investors may have in investing in some of these instruments. I think one thing that we shouldn't discount is the significant interest that various funds, various development finance institutions, various, you call them PBOs, public benefit organizations, and funds have in investing in healthcare in Africa. So it's not an issue of lack of funding. It's an issue of us being able to get together, getting the policymakers in a room, providing clarity on exactly what is required. If it's to develop manufacturing capacity, we've seen a lot of activity from entities such as USAID and DFC that has provided either direct funding or guarantees that allows our manufacturers to export and to sell locally into the market. I think that the key thing that financiers look at is the source of repayment. If you're talking about commercial banks and even development finance institutions, the source of repayment. If we go further into the capital structures, just above what the equity investors would be looking at, you're also looking at providers of patient capital or purpose-driven capital who are not really looking at a return of interest. Maybe some will be looking at return of principal, but there are others who just give straightforward grants. What they're looking for is certainty that the funds will be used for the right purpose. So if it is to support the community-based structures, that's what we really need to work together and ensure that we're driving that. If it's to support manufacturing or import substitution, then we would structure the solutions around that. So I just to answer your question, I don't believe that the risk mitigants that the investors are looking for are hard to come by.
All right, thank you. Professor Kihara, I'll come to you. This is something you want to say? Yes. And then I wind up with Francisca and we pick questions from the audience.
Yeah, we've been talking a lot about PPP. I'm very practical. We have a group of Rotarians who have been in this country. We did an M&H plan. I'm looking at M&H, but with the extension, it can be extended to global health security issues from 2016. And all they ask is, what will be the social impact of our engagement? And what they do is you raise an amount of money and they give the matching equivalent in partnership with international bodies. So similarly, we do have quite a number of those kind of philanthropic bodies that are willing to plug in, but clearly with the agenda for social impact. So I agree with you, this is one way. The other is the venture capitals. We're not really talking about it here, but we have venture capital as an alternative stream we could possibly consider. Private equity, angel venture capitalists, they are there. Again, it could be an area we could explore. The third I want to speak on is grants. Constantly looking for grants that speak to how you can strengthen, particularly your health system, in addressing now global health security related issues, in addressing capacity building, and in addressing equipping.
All right, thank you. Francisca, how do we incentivize the private sector to play a bigger role in financing our future and ensuring it? And the reason I ask this is because you already have a learned experience on integrating with the private sector. Perhaps mention what your sources of finance, how did that turn out to be? And in terms of utilization, did you use the money as envisioned?
Thank you. Maybe because we are sitting close to each other, and we deal with the same subject, which is maternal health, just to emphasize what has been said about the importance of involving women. Just to give two examples from the COVID-19 response. I mentioned here the way we managed it. When the key change happened in terms of important issues at the social level, like vaccine hesitancy, misinformation about the utilization of vaccines and the other interventions which were being called for by the countries, the Africa CDC, the trick was made by women. The community health workers and the community volunteers who were dealing with this, using the funds which were managed by us with the different players on the ground. Concrete examples from the ERC and the Swatini, where women working with the Red Cross managed to change the whole situation and improve the uptake of, guess who did the trick at the community level? Community radios. Was not like a journalist like the master of ceremony, highly professional journalists, were the community health radios that made the trick and allayed the fears and contributed to the uptake of the vaccine. In terms of the private sector, which is coming to your question, I would say we provided that platform. That's why I emphasize the importance of Africa Public Health Foundation. Most of the money we managed as grants, which was applied in 17 countries, was not from state actors, was from private philanthropy, corporate social responsibility. And now we're taking a step further and we're engaging with the private sector. I don't think that is appropriate for me to mention names here. I don't know whether they're in the room or not, but just to say that we are going in that direction. I had some conversation with some of the participants here who belong to that sector to see how we can move forward. So in catapulting to the future, as we are trying to devise mechanisms how we respond, I would say this is a platform that we need to have in place in tandem with what the state that contribute to make up this region in terms of East Africa region, they'll get their own public money, they'll get their pooled mechanism to provide funding for the response, but how we get the private sector, how we get the social responsibility, how we get the philanthropy. And that's where we think Africa Public Health Foundation could provide this platform and bring this, I wouldn't say confidence, but the ease. You need to get the private sector participants at ease when they provide their funding and they don't go through the complicated mechanisms that you get when you go through the state actors. I think that's an advantage. And if I could beg your indulgence, Chair, to address one comment I wanted to make in the previous session from the eloquent presentation by Dr. Casolo. The colleague from World Bank, I don't know whether it was you or another one, was mentioning the issue of lack of commitment, if I might use this expression, from the countries to buy the produce of their own manufacturers. There is an important issue here, to me, is what I want to suggest. Let us get all the critical players in this discussion. There is one brother of the World Bank that should be here, the International Monetary Fund. That's the crux of the problem. Because you cannot expend more than you agree with them. I wore a hat of Minister of Health for 5 years in my country, Mozambique. I went through 2 painful experiences. We set up a factory to produce oral rehydration salts. It was producing high quality, but we could not, as a Minister of Health, buy and provide these to our health units. We were flooded by donations from different organizations, and when we were buying from our own factory, we had to answer these questions. Hey, why are you using this money when you get the things for free? We said, we wanted to support our factory. I said, no, then we're not giving you more money if you have excess money to spend. We went to another experience, because it's a cholera-prone country in Mozambique, particularly Beira, where I stayed there for 12 years, doing maternal health, as I said. We were hit several times by cholera, and then we were importing IV fluids. And one investor said, I'm going to set up a plant to produce IV fluids. He started, and we could not buy them, because they were, each unit was 3 times more expensive, which is expected, than the imported one. And then we were not allowed to buy the local produce because it was more expensive. That has to be expensive. Who are studying? So this is important. Next time, let us get the IMF people on board. There is a critical issue. We talk about the importance of getting the bedrock, which is the health systems. This is how should be our response, is to get the robust health systems in order to respond to the pandemic. Critical element, human resources. You cannot hire. You train them, you cannot hire because you reach the ceiling. You have to deal with the IMF. I think this is extremely important. It's not lack of will from the government. It's the whole environment in which the countries operate that has to be changed. Thank you.
Thank you. I don't think we can have better closing remarks. Cliff, I will ask that we have a revolving mic. If there are 2 questions from the audience, I am happy to take them for my panel. Possibly 2 questions in the interest of time. If not, we will be winding up. Any 2 questions? All right. I don't see any hand up. I think I will attempt to summarize the conversation we've had here. And we began by saying what we are trying to do is to trigger thoughts so that when you go back home, we are better prepared. And this conversation was about finance, public health, and long-term preparedness. And 4 things that have come out are that we must invest. We must invest in systems that bring all these things together. We must invest in our people, because pandemics are not just about diseases. If you do not have the right personnel, you will have a pandemic in your hands. If you don't have the right system, you will have a pandemic in your hands. A conversation on commodity security and sufficiency has been said, and it is important that we pay focus there. There has been a strong focus on people. One, at the community level, there has to be important and relevant awareness so that in the event we have a pandemic, it begins and ends at the community level. In terms of education as well, we must invest in our people and educating them, and also the clinicians. And remember the at-risk populations. We've had our women and most of those who are expectant remain to be in this category. We've talked about finance, and my appeal to all of us is that when we go back home, we must pay a lot of focus here. And I think one of the things we must think about is creating a pandemic fund. And how do we resource this pandemic fund? Do we think of making it a tax-deductible fund? On the first day, we mentioned an idea of having also, before you pay your taxes, you contribute to that fund as an organization so that that can be a tax-deductible expense. Catastrophe bonds, contingent convertible bonds, are these instruments we can use to fund such a fund. And then there is the interplay of all this, and it ends up at politics. Politics are important from where I stand. And the reason I say this is because they determine how resources are allocated. And without money for preparedness, it is impossible to have this going on. So for politics, we must make it politically profitable for the wrong people to do the right thing. Isn't it? We must make it politically profitable for the wrong people to do the right thing. Because if we don't do that, even the right people will have no incentive to do the right thing. So when you go back home, I think that aptly summarizes the conversation we've had. John, I will allow a 30-second comment.
Thank you very much. You're very gracious. But I thought it's important to just highlight the approach that KCB takes as a financial services provider across the region. So 1.5% of the bank's profits goes towards the KCB Foundation. And that foundation purpose is to ensure that it supports the objectives of youth and the communities that do not always have the opportunity. So we support youth going into entrepreneurship. We support education. That is on one spectrum, and I've already spoken about FLAME. On the other side, on the corporate banking side, we can lend up to 20 billion shillings. So if you're thinking of large-scale funding and manufacturing capacity, we can look after that as well. We also have strong relationships with development partners. For example, we have signed up with the DFC, a $10 million guarantee scheme. So if there's any the entity here that's looking at getting some medical equipment, we can see if your requirements fit into that scheme. The message is our doors are open. Don't be shy to come with your ideas. We'll be able to figure a way out. Thank you.
Thank you. I think Chairman Nzai, you have heard where the money is. And I think as we are bringing the meeting to a close later in the day, we can reach out to them so that we get this rolling. Hopefully we shall have a Mombasa declaration or a communique around this so that we can bring it together. I think the final thing was that we were to have Jane Ngugi from USAID here with us. Due to the existing extraneous circumstances, she couldn't have been here, but she passes her regards. And we've had Professor Kihara ably have a conversation with us. So folks, without much ado, allow me to request that we clap for our panelists. And I will request we stand here and have a photo and call Laban up to the stage. Thank you.
All right. Thank you very much, team, as well. That photo marks the end of this session. Please give them a round of applause, ladies and gentlemen. We're looking at financial instruments for sustainable health preparedness, ably led by Team Theory as well. Thank you so much, panelists. Ladies and gentlemen, I wish now to draw your attention to the screen in front of us. Did you know that today is the NTD Day? That's the Neglected Tropical Diseases Day. Well, commemorated annually on the 30th of January, globally over 1.5 billion people are affected by these diseases. The World Health Organization has listed about 20 of these diseases, and they are called the neglected because they're ranked very low on the global health agenda, thus receiving very little attention and funding. As of December 2024, 54 countries have successfully succeeded in eliminating at least one NTD. Ladies and gentlemen, that's our intro. Please train your eyes on the screen in front of you. Please give a shout out to Professor Samuel Karaoke, please, who's in the audience. I ask him to please stand. Savri, just please come on stage. I think we've seen your video, but it's good to appreciate you in person. And then wish your neighbor, of course, a world and happy World NTD Day. Is there any other staff apart from Prof and as well? Mercy, thank you, from communications. Any other team as well? From the NTD team? Okay. Please stand. We want to appreciate you as Prof speaks.
Thank you very much, MC. As my team comes up here, just again to reiterate that this is a big day for those working towards finally eliminating neglected tropical diseases. These are diseases long forgotten by the developed world, but they're still with us here for a reason, because they are among the most neglected of populations. So we no longer talk about NTDs, we talk about neglected communities and neglected populations. How best can we serve them? Really, we cannot forget certain sectors in our population because they are with us and they are part of our ecosystem. If they are properly cared for, medicines reach them and they become treated, they become productive members of the society, and they turn around their own fortunes, they turn around the fortunes of those that are in the households and those that are in the community. And of course, by extension, they become part of a growth for our nation. So we cannot forget that population. My call today is, as we celebrate NTD Day, let us not forget neglected populations. Let us not forget that it's us to make their lives better. Let's not forget that it's us to deliver those medicines that we produce at affordable prices and effective for treatment, management, and eventually elimination of these diseases. So wishing us all a very, very successful World NTD Day. Thank you.
Thank you, Prof, from the NDI as well, and together with your team. Yes, wishing you a very best World NTD Day. What a segue into our last panel session for this morning session, as before we do our breakout, which I'm advised we'll do just immediately after lunch, and then we can come for our closing session. So just to note, today, ladies and gentlemen, as you note, we have our closing ceremony which I would kindly invite us all to. I know we have pending flights and travel back home, so if I could kindly ask you to please be back at about 3 p.m. where we can have our closing ceremony. Just to note, we are going to do our breakout sessions in the afternoon, so we'll have an early break for lunch, and then we can come back by exactly, so we have the breakout session between 2 and 3, and then we can be here by 3 sharp as well to start our closing ceremony. So with that notice, I urge us all to please adjust our schedules accordingly. And as we do, please help me invite on stage Erica Chola, who is going to lead the Building Trust and Health Literacy. That's the role of risk communication, a subject I'm passionate about, on community engagement in health, emergency preparedness, and response.
Hello, everybody. Hello. I know we've been sitting for quite too long. Please allow me to invite us to be upstanding. I know we're just about to go for a break, but allow me to invite us to be upstanding just to get us a little bit re-energized as we invite our panelists up front. So please speak to your neighbor on the left and just ask him or her a very simple question. Do I know you? As we do that, please allow me to invite our panelists, David, Professor Anne, and then Onesimus. Please come on stage. So David, Professor Anne, and Onesimus, please come on stage. So now, turn to your neighbor on the right and ask the very same question. All right. So let's get seated. All right. So do we have Onesimus in the room? From LVCT, Onesimus? Okay, the time for catch-up is over. So please, let's take our seats. Let's kindly take our seats. All right. I'm actually happy that we got to interact, and those of us who are going to leave this particular summit without making a contact have succeeded in making at least one contact. So, ladies and gentlemen, my name is Erica Chola. I work with HELTH Africa as the Global Communications Manager based at the HQ, and it's my honor today to be moderating this critical discussion on the role of crisis communication and community engagement in health emergency response. So if there is one particular lesson that the past years and of course the past experience has taught us, is that information can save lives, but only if there is trust in that information. So, how we communicate determine whether the communities that of course we target comply with that bit of information, but then they also comply with the public health measures that have been put in place during crisis. So it's a honor, and with me today, I have a distinguished panel of experts we initially were privileged to have a panel of 3, but our privilege has been extended. And of course, due to time, and the panel has been reduced to 2, which is still fine. And it gives all of us an opportunity to get to hear a lot more from David Weme and Professor Anne, who has also just left another exciting panel conversation. For those of us who missed some of her submissions, please get ready to hear a lot more about some of the insights that she would have for us today. And I would want us to have a very interactive session. So there is a particular question that I would give to the audience. 2 questions. One has a reward. So whoever gets it correctly would have a reward from me. And then the other, of course, doesn't come with a reward. Unfortunately, the one that doesn't come with a reward is the most difficult one. So I will put it to you and give you enough time to prepare for it. So let's get to know a bit of our panelists. So David works for AMREF. He's a specialist in the field of medical anthropology and with a specific focus on the social determinants of health. So if there is something that is so unique about David, and just one special thing about him, is that he loves classical music and he also plays cello. So anybody who would want to interact with David beyond the professional discussions, feel free to talk to him about those components. And then Professor Anne, she is the president of FIGO and very passionate about what she does. And FIGO is the International Federation of Gynecology and Obstetrics. And this is a global umbrella that is bringing together members within that profession. And I think it's the only one, right? Yeah, and you'll get to tell us more about that. She's also a senior lecturer at the University of Nairobi. And one thing that is special about Anne, and I think most of us have already noticed, she is the global voice for women when it comes to issues of health. And I would want to quote a statement that she mentioned as we were just having a chat before we got here. If I can make a difference in a woman's life, then I am home. What an incredible statement to come from an established and an experienced expert like Anne. So let's dive deep into the conversation. I know David possibly also has a statement of his own, but it's fine. We'll not read it out today. We'll give him an opportunity on the next platform to talk about it. So to get us started, I would allow each panelist to just quickly give a 1 minute or a 2 minute remark about really how they perceive this whole topic about crisis communication and community engagement in handling or in scenarios of public health emergencies. So, ladies and gentlemen, feel free, and allow me to begin with David, so then we can get your remarks before we go to Prof. David, over to you.
Thank you very much for that beautiful introduction. And I think that there is some shared experience here behind the professionalism. Apparently, my fellow panelist also sings, so the music is going. What I want to briefly reflect upon when it comes to risk communication, community engagement, and what WHO recently added, infodemic management, is that this is about the last mile, trust. We can have our public healthcare and primary healthcare infrastructure. We can have our medicine. We can have our factories churning out medicine, and we can have the infrastructure reaching communities. But if those communities are not taking these medicines, what is the whole reason of having these infrastructures? So trust here is essential, and trust is being established through the right communication, the right partners, and trust takes time to build. Like you said, I'm a medical anthropologist, so I'll go academic on you in a minute and break trust down. But then I'll be more clear on how trust can exactly be built and how also fragile trust can be in health crises. I'll stop there.
Thank you. Thank you, David. Anne?
Thank you very much. And I'll just add on to what David is saying. And trust, to me, begins really at the home front. One person you really need to convince on any issue is really the woman. Because if it's giving the children medicine, if it's supervising the husband taking medicine, she needs to have been convinced. So what is her health literacy? Number two, to cultivate that trust, data should be speaking to us. So data-driven information. So when you do have a crisis or an emergency, that's the other piece that must be there. The third thing is, how do you curb misinformation or disinformation, the infodemic he's talking about? Data really does that, because whatever is evidence-based is factual. The third layer is, how do you then change behavior? How do you change behavior? Behavior is driven by a lot of things. My anthropologists can speak to that even better. But really, the advocacy piece speaks to getting a message across for social behavioral change, communication, and for accountability. I would put that as the forefront.
Thank you. Thank you so much, Prof, for that. Now, allow me to take you up on a very important statement you mentioned about health literacy. So how can health literacy be improved to empower communities during health crisis?
I will start with a practical example. It's close to lunchtime. So I want one of the young people in the audience to tell me, in Sheng, it's lunchtime. Any of the young ones, they're here. They might not want to speak. Say it. There's a language they speak more oftenly that articulates only to them. Then we have the layers of our own ethnic language. So if I was to speak in Swahili, ni saza nini? Saza nini? Waswahili? Aya, kula chakula ya mchana, eh? Is that correct? Yeah? That's my ethnicity. In Cameroonian, he would speak in French and tell me something else. What am I trying to drive at? Health literacy, you must reach a point of language of understanding. I can confabulate all the medicine, but if my village lady cannot comprehend it, will she act? She will not. So I think we have a very beautiful platform today that didn't exist before, where we can even use communication using AI as a companion. But more importantly is to remember, whatever messages you're saying up here must percolate to the last mile in simplicity, in clarity, and in a language of understanding, so that you're communicating bi-directionally and not being looked at like you're actually dictating upon an individual. This really requires the community centrality. They need to know to be able to then take action.
Excellent. And when we talk about taking action, there is a component of trust that I would actually want David to come in and talk about. How do we build trust? We've already talked about a couple of components, but I think, in fact, instead of talking about how we build trust, let's make it a little bit interesting. How do we measure trust? I know that's an interesting area of your work, but before you come in, allow me to pose the first question to the audience. So I just want to give you the question, brainstorm, and we will have the mic, of course, with the permission of Laban. We would have maybe one or two responses from the audience. So what policy shifts are needed to ensure crisis communication and community engagement are institutionalized in public health response strategies rather than just being treated as an afterthought? I repeat, what policy shifts are needed to ensure crisis communication and community engagement are institutionalized in public health response strategies rather than just being treated as afterthoughts? Remember, that is the most difficult question, and it doesn't have a reward, but the mic is coming. Thank you. David, talk about how we measure trust.
Thanks for that. Yeah. Measuring trust. Where would you start when you want to measure love, or when you want to measure ambition? I mean, those things are difficult to grasp, right? So let me break trust down like I promised. Trust is about you and other people or institutions. It's about consistency. It's about reliability. So can I rely on someone to be consistent? If not, why would you trust that person or that institute? So when we speak about measuring trust, it's not one moment where you can put a thermometer into a community and say, well, they trust the government. Now, this is a lengthy process that starts way before any outbreak and continues into eternity. And it doesn't only start or end with health. Now, when we measure something like this, let's call it a social aspect of life, you start at talking to people. Medical anthropology is about talking to people, about curiosity. What we do is we establish trust within the community first by reaching out to a stakeholder there, someone who's recognized within the community, and ask that person, how do we go about it? So you start in a co-creative method. You start by making connections with the people on specific and influential positions within that community. If you want to measure something like this, you have two ways, in my opinion, quantitative and qualitative. So how would you capture trust in numbers? Send a survey to someone and say, how much do you trust, I don't know, the government from 1 to 10? Is that really going to give you something to work with? No, but it gives you an indication on how much the government is being trusted. Now, the second step you need to do, so this is mixed methods, qualitative and quantitative, is ask for explanations, the stories behind the numbers. So the numbers give you the surface, the stories give you the depth. They let you explore how people do or do not trust. And that can give a very different story as well than the numbers. Maybe someone gives an 8, but then when you talk to people, you hear different stories about mistrust because of not being consistent, because of previous crises and emergencies that did not go well. So in this way, you try to compile a complete picture of trust. I'll stop there.
Thank you. Thank you so much. Now,
I want to
Prof,
add.
As you add, please bring out the component of gender when it comes to that component of measurement. But also just keep in mind, once you're done answering that, I would also want you to also talk about engaging young people. You talk about the language, the different audience groups. So how do we engage young people in this digital era that is also full of skepticism? Over to you.
So keeping ourselves relevant to global health security, I want to engage the audience and my good friend, Dr. Lucy in front here. And you will just tell me female or male. Most of the healthcare provision was provided by, during COVID, female or male? Female. Most of the leadership was provided by, most of the people addressing care for the sick were. Now, I don't think I need to elaborate gender as clearly, an area we must focus. You've answered yourselves. We need to really not flag it for the purpose of just doing so, but really look at the roles and responsibilities that one is given during the time of addressing a crisis and emergency situation. Do not forget, it's the same woman who will also be carrying a pregnancy. So not only is the risk for herself, she could be pregnant, and she could also be nursing her children and the extended family, because we are communal. That's one. Number two, in gaining trust, there must be the feedback arm. It's not just about supplying a service. So accountability. Are my policymakers and duty bearers accountable? Are the services I'm being provided accountable to me, who is in the community? So yes, we had COVID, and we were told you must do the wash, you know, the masking and the daily cleaning of hands and getting the vaccinations. Access became a problem. And the ripple effect actually came as a demand from communities. We too need to protect our people. So for me, in trusting, you have told us, do I take it up? That really is the culmination of showing I trust that my best interest is at hand. Now, looking at the adolescent and the youth, this is a very special layer. They don't like reading. They don't like hard things. Even David here, he's in a cello, he's playing instruments. The main thing is for the young is look at what medium they prefer to use. Social media for them is the go-to place. I'm born before computer age, so I'm a little bit diehard. But for them, if you really want to get a message across to them, it is one, plugging in with their language, plugging in with their medium of communication. Oftenly, it'll be the Facebooks, the LinkedIns, the Telegram, and it will also be the TikTok. TikTok, 1 minute, you've got the message across. Because even we've recognized that attention span, they want the message, they want the value provided to them instantly. So I think we also need to bandwagon in their space, and also to recognize a lot of them have got community networks amongst themselves. So if I ask them to put out their WhatsApp, you'll probably find about 100 other young people communicating with them. So it becomes a very good medium to translate and relay information. But again, it's also a source of disinformation. So how do you crystallize to make sure that the messages they are getting are sound for them?
Excellent. Thank you. Thank you so much, Prof, for that. Now, you have mentioned something very critical, and it just reminded me of a conversation that we were having out there. I got to reflect of an experience during the peak of COVID. I was engaging with journalists, and the amount of requests that we would get for information was massive. Most of the time, the journalists would not be granted access to the right people who are providing information. I could tell the level of frustration on their faces, and even from where I sit, from a professional standpoint, I could see how much that was impacting, public information, because there were critical decisions that were made in government. And when I talk about government, I'm making reference to the government of the Republic of Kenya, of course, with the Ministry of Health that was leading the response during COVID at the time. So I saw a bit of frustration, and the public is out there, there are people coming up with myths and misconceptions about the vaccines, the containment measures, but then when the journalists come for information, they don't get it. And I know there are a couple of journalists here in the room, and it would be great to hear from you, just in case there is one who had an experience like that during COVID. So, Prof, and David, of course, I'll be coming to you next, so don't sit comfortable. Tell us about this whole idea of being open with information, and how can we also tap onto the component of working with each and every sector to ensure that the right information is delivered by the right people in the right way, as you already mentioned, with the right channels, targeting the real issues at hand.
That's a very good point, and I really want to accolade the Fourth Estate. That's what we call them, the Fourth Estate. They must be integral from the outset, especially when you have emergencies, especially when you have a crisis. We don't need to go far. When we look at what is happening globally, the Fourth Estate must be with us. But they also need to recognize when we're dealing with something that broods on security, health security issues, you must be able to appreciate there must be a coordination mechanism, a cascade mechanism, correct data-driven information before you communicate. That has to be in place in that sequence, because you may just abstractly communicate, you may end up miscommunicating or disinforming the public. Note, their role speaks to everybody. I actually call it the diplomatic role that they play in terms of speaking to the highest, the duty bearers, speaking to the mid-level, really, which is us as the care providers, and speaking to the community. So we've got to get the information data-driven before you can actually articulate yourself. Number two is recognizing champions you can relate with. Sometimes you may be looking for a co-clinician who really is not even a communicator, because we've got different talents. But you may also have champions that you can say, if you really need sound information, that's the to-go place person. Number three is the use of even getting the word around faster, also recognizing some of the celebrity personalities within the community that you can also sit next to and buy to actually get a message across.
Excellent. Well stated, and I would not want to take anything away from what you've said, Prof. So, David, there is a question here for you, but before you respond, I would want to come to the audience to see if we have a few contributions on the question that I asked. So, David, let's talk about, when I come back, feedback mechanisms. So what are some of the best ways to incorporate community feedback into community management, into crisis management strategies, which I think it's very important. For now, I don't know whether we can have a roaming mic. Anyone who would wish to speak to the policy question? Anyone? And I would encourage somebody from another country other than Kenya. Is it that because this question doesn't have a reward? Okay, thank you.
Thank you very much. Very interesting discussion and contributions coming from the panelists. I think when we look at policy shifts in crisis management, I think we tend to think of those shifts when the crisis is there. And I think that is the wrong time. For me, we need to have it as part of the routine work that we do every day. So if, for example, we are training people, we are trying to develop policy, that is when we should be thinking of crisis management and building the trust. And I was going to say that just in addition to that, one of the things that we always think is that we can go into a community and build trust. But there's already a formed opinion on you as an organization, as people, before you actually go into that community. Many, many years ago, I had an opportunity to be sent into the interior of the Democratic Republic of Congo in a place called Inongo. It's by a lake called Lake Maindombe. You fly in on Monday, the next time you fly out is Friday. There was a ravaging polio outbreak in the DRC then. And we had sent who we thought were the best epidemiologists, the best public health nurses, community people, to create demand for that vaccine in this community. And things were not improving. So we then were deployed there to go and have a community discussion to find out what was going on. And for me, the lesson I learned was that sometimes when we go into communities and we're speaking to them or telling them what we want, they politely shut off and keep quiet and say, yes, we've understood. And coming to how do you measure trust? If you ask those people, did you understand the survey? They will tell you everything, yeah, we understand. But when you leave, they won't do that. And as we found out, what the problem was that we had brought people that they had never seen working in that environment to tell them to take certain actions. Whereas amongst themselves, there were community health workers who had previously worked in, who were totally sidelined. And when you dug, you were told, the people you brought in, just sit in their offices, put loudspeakers on vehicles, and then come into the community to tell us on what to do. We understand what they're saying, but how do we trust what they're saying when they don't live amongst us? They will leave, and then if something goes wrong, it is us to ask the question. So change things. That man who's sitting under the tree quietly listening in is a person we trust in this community. If you make him our leader, we are going to listen because he has never told a lie in our community. So it's that complexities that we need to be taking into consideration. They know what they want. The communities know what they want. What they want to hear is how they can best deliver what they want, not what we want and asking them to deliver. So again, that's why I'm saying it should be policy shifts in crisis management should be part and parcel of the routine work that we do in communities with the people that live in the communities.
Thank you very much, Dr. Kasolo. But maybe just to add on to that comprehensive remark that you've given, I think one of the other important issues is generating specific evidence to drive the policy. Because I think most of the time, we'll pick up a global or international policy and say, let's adapt it. So we change the language, we change a few words here and there, but it's not contextualized to the situation on the ground. So we need to be able to, even within the same country, there are dynamics between tribes or areas, because, you know, driven by culture and so on and other issues. And so it's important that even as we push to put in certain policies, they are evidence-driven. And the evidence should be coming from that particular community or that particular country, and not duplicate or replicate and say, oh, this worked in Zambia, therefore it must work in Kenya. So evidence-based is what I would add on to that remark. Thank you very much.
Thank you so much for really those illustrative case studies. And there is actually just one thing that I want to pick up, and David, that is tied to your question on feedback, because if you listen to the case study given by, of course, Dr. Kasolo on the DRC experience, the community had everything that they needed. You know, it's just that they did not follow the right procedures, and they didn't have the right people. So how do we get to harness that feedback and put it into the strategies to help community engagement a lot more effective during crisis? David.
Yeah, thanks for incorporating those thoughts in the question. In anthropology, we have a word for this. It's called parachute anthropology. So you come from somewhere around the world, they drop you, or you drop yourself in another part of the world, and you expect then that you can get to know about the people who live there and their customs. But it is always such a long road from saying hello to someone, a friendly hello on the first chat, to that person confiding you in insights in the way that they, you know, behave within their families, or the tensions that there are between different ethnical groups. So it is paramount that in a case of emergency, we use structures that are already there. Now, this also calls for an increased collaboration across different regions within the country, but also across country. Because how would you know what is already there if you didn't map it out, if you don't share that information across the region? And maybe we're going to come back to that later. But if you know these existing systems, then the feedback mechanisms come natural as well. And feedback mechanisms can be spoken or unspoken. And unspoken, an example that was given here was saying yes, doing no. But other examples are resistance, as it is being called. Now, an example of that during the Ebola crisis in 2014 is one of the first engagements of the response to a community close to the border with Guinea. I visited that in 2016, so after the outbreak, to look into the role of social scientists in the Ebola outbreak, because this Ebola outbreak really set the stage for inclusion of social scientists, which was spoken to by our WHO colleagues in the opening remarks as well. Now, imagine you're living in a rural area in Sierra Leone, close to the Guinea border, and one of your relatives dies. And most of you will know Ebola is, it's also called the zombie disease when it comes to the way that people finally look when they pass away. So it looks horrible. What people don't know causes fear. So there's already part of fear there. Now, someone or a group of people come to your community. You know that you don't know the people. They are dressed in PPE, personal protective equipment, which looks like beekeepers' equipment, so you don't recognize the person at all, and they spray chlorine all over. How would you react if something like that happens to you and they want to take the body of the deceased? You can't touch it, you can't give it the custom burial that you want to give it. That's why in Sierra Leone, resistance erupted and community health workers died due to that. There was violence. Now, this is also feedback, but it's not the kind of feedback that you hope to have, but you learn from it. If you don't know a disease, there's a longer way to go than when you already know what you're in for. So this is an emergency where you have to learn from, but then feedback mechanisms which are already established through existing infrastructure between localized and regional health facilities, those can be capitalized upon. And what was mentioned, social media is becoming much, much bigger than what was thought before in addressing the concerns of communities. Because you'll find everything online, everything that's going on. People, you don't have to ask people anymore, they just put it out there. Now, the problem here is what is true, what is not true. What do you take into account, what do you not take into account? But these systems, I think, are categorized in those that those that are unspoken and those that are spoken.
Excellent. Thank you so much, David, for really just highlighting those critical components of feedback. There's a component that you mentioned that I would actually want to pick and push this to Prof. And this is actually our last segment. We're counting about, in 5 minutes, we'll be done here. So, sharing of information, of course, looking at the region. And so we're operating within the East African community, but then, of course, we have the continental structures. So how is collaboration key in addressing the regional health threats? Because definitely no one country can work together in handling crisis.
I think that's a very important approach. Number one, with global health security, we are having porous borders. Porous because we're sharing our healthcare, we're sharing our trading, we're having people migrating back and forth. So it is critical. You cannot say, I'm staying as an island in Kenya. I certainly have to know what's happening both in the continent and beyond. So that in and of itself makes collaboration extremely important. The second layer even speaks to capacity building. We are in an age where we can use a lot more digital technology. So even the education and capacity building, you have the porousness of borders no longer being an issue. And the fact when you do have an emergency, you've got to shift people from different countries to come and actually assist. So the education capacity building, I think ECHO is in the house, is one example. So you cannot say, I'm going to deal with this acute crisis or emergency on my own. The third layer speaks to financing, where you have pooled financing as a possibility by virtue of communicating with the next country or next region. You can actually have pooled financing for infrastructure, pooled financing for the medications that may be needed. Similarly, what happened for all of us during the COVID pandemic. So I feel the collaboration and the synergism of approaching crises and emergencies actually adds value. But again, trust. Trust. I think it came even from Tedros, where he was very clear, the Director General of WHO. Partnerships is not just a come, paste, and go. It's about building trust, building relationships, remaining focused. This has to be tackled. So as long as your vision and your goal is in tandem, then the collaboration is easier to pick up.
Well said. The final bit of this. I would want to come to the audience. But I would also want to invite David and Prof for just quick final thoughts. But before I come to you, allow me to come back to the audience. I do not have any particular question. The initial question that I'd promised has been overtaken and it's been responded to, so I'm not going to ask that. I just want to ask for any additional reflections or any additional points that we would want to consider, or maybe as a takeaway from this particular convening. I know we've listened to really incredible case studies, very great examples that we can learn from, key lessons. If there is anything else that you feel that is so striking that you would want to contribute to this conversation, then this is your time. Or maybe if you have a question, or maybe just one for the panelists, then this is the time before we bring this to a close. Thank you. Thank you so much. Doc, any mic on the floor?
Thank you very much, the panelists and the moderator. My name is Francis Namisi. I work for and with the University, Amref International University. I just wanted to make some observation or comments. You know, I know resources are very critical. You remember we are already in a crisis. And therefore, when we start looking at the policies which are a process issue, it means that this is the time for us now to be also disruptive. Yeah. Look for the best, yeah, stabilize, and then be able now to look at what the policy actually means. I want to add on Prof's maybe comment or things that we have to consider. One, we know that money is important, but human capital is the greatest, in my opinion. Because if we read from the same script, if the community reads from the same script as we, as the professionals, it makes the work easier, the load easier, and even the reach much wider than we planned for. And therefore, I think many times we have a challenge because our communication is desktop design. And a desktop design does not take into consideration the contextual issues. Let me end up by telling a story from Zambia. We walked into a community and the Minister of Health said, we were working with UNICEF, and they said, oh, this is a place we frequent, yeah, many times, and the people know us. And then we did an analysis where the community had to reward the people that are closer to them. And for your information, I'm sorry that the Ministry of Health, Zambia, was on the periphery of the peripheral. They were not any closer. The people who are closer were the social workers, yeah, the teachers, the chiefs, yeah, and other leaders, the religious leaders, and that is those are the people that work with them. And what my senior here talked about, especially when the communities say, yeah, they drive around, yeah, they come here with big cars and speakers, and then they are gone, but we live with these other people. Let's look at the context. Thank you very much.
Thank you, thank you. Thank you so much, Francis. Dr. Kasama?
Thank you very much. Just two items that I wanted to contribute. First of all, it's obvious that we have a capacity gap in terms of we, the responders, or the health workers, or community health workers, being able to build trust and indeed put across our health literacy messages. So one of the things that we need to start thinking is really incorporating some of these modules into the way we teach health workers, the way we teach the community responders, the way we expand or the research teams that go to respond. That they are excellent epidemiologists, they are excellent infection prevention persons, but are they really excellent communicators? Can they get the message to the community? Can they get the communities cheering on to what they're saying? So I'm suggesting that those that are in academia, those who are in training, please, let's look at generating a module that will empower our responders. Secondly, for a long time I've seen that the methods of generating or providing the health literacy has remained much the same. So innovators, are there new innovations that we can put across? A couple of years ago we did an innovation survey on the continent. And one of the things that stuck in my mind was an innovation that an Ethiopian gentleman had built on mental health. And this young boy has now set up even, I think, a radio station which speaks nothing but just mental health. And targeting who? Targeting the youth. Because much of the mental health they were dealing with were amongst the youth. So can we start contextualizing innovations that target where the problem is? The days of flyers, the days of cars moving in the community, the days of radio stations playing jingles are long gone. Can we look at new innovations that are targeting those that are receiving? If it's in the villages, the illiterate, what innovations can we use to get the same message? If it's the Gen Z, what innovations can we use to target the messaging? So two things, capacity and innovation. I think it's something that I would like to contribute. Thank you.
Thank you. Thank you so much, Doc. So we have to bring this to a close. So let's have a quick
Eric?
question.
Yes.
Okay, go ahead.
Okay. My name is Barak Magdalene, a student at Amref International University, and I just have a quick question. We're talking about building trust and health literacy, yeah? And for the longest time possible, we've always been talking about there is nothing for the community without the communities. That has been talking. Have we been walking that particular talk? And we've noticed that most of these particular communities act as beneficiaries rather than acting as collaborators. Because I believe from where we sit, and if we stop looking at these communities as beneficiaries of the policies that are actually put in place and look at them as actually collaborators in these particular policies, then we'd get to have a different type of result. So my question is, what structures do you think exist within our communities that could help us in probably pandemic preparedness and also the health security within the communities? And if there are none, what do you think we can be able to do so that we can ensure that we have structures within different communities to ensure that we actually let the communities take charge of their own health, and once we have an emergency or a pandemic, they're able to take care of their own health from where they sit, rather than waiting for policies to come from a national level so that they can be able to mitigate the issues that are within the community? Thank you.
Thank you. Thank you so much, Barack, for that great question. So, Prof, you want to give it a try? But David, also feel free to come in. So as you respond, please give us your concluding remarks as well.
Okay. Nothing for us without us. And I will also accolade my WHO representative here, who's really speaking to capacity building. Advocacy does not come just like that. It's not ingrained in everybody. And that is a skill we certainly need to inject, particularly in our health structure in terms of where we train. Because I've, over the years, even gradually graduated from just being a practitioner to becoming an advocate, because you realize that there is a huge gap. How do they articulate with the policymaker? How do they articulate at their own level? And how do you articulate even more so with the consumer we serve? That's the community. Community does have structures, because it starts with how do you make community entry. And we have gatekeepers. Depending on what your agenda is, are you dealing with the household? Are you dealing with the chiefs and the village headmen? Or are you dealing with, you know, the structures are there. In the case of global health security, entry into a community is critical. And you can bandwagon on what exists. Climate change is bringing challenges. Malaria is a problem. HIV. You don't need to recreate it, but to plug in to those community entry structures. The second layer, once you've had community entry, is become an elephant. Grow bigger ears, keep your mouth shut. Learn first. That's what I always say. Grow bigger ears. Because in listening, you understand their context. You also need to be the researcher who then does the landscape analysis, further emphasizing the context, the culture, the access issues. Let them speak it out. As my colleague here, David, said, be more qualitative in your approach within a community. And it's only then you can come up with a the word is co-created solution. Not a dictatum. Or to say, we've had this done and working in this place, we're going to copy-paste. That's not the way it goes. You must create a homegrown solution so that it's owned and institutionalized within the community. That's what I would say.
Thank you. Thank you. Thank you so much. And David?
Thanks for those last great words. Very inspiring. I would want to pick up the second point on innovation as made in a remark by the WHO representative. And that is that those are there. We can already see them. I used to do a lot of work in the MHPSS field, mental health and psychosocial support, specifically conflict-affected settings, but in this setting we have developed an app, as simple as that. An app for people to install on their phones, they can go to and get some very basic information about mental health in an accessible way, in a way that is friendly to the culture and contextualized. It is being developed together with the people from that community, support from private sector, government, the organization I worked for, an NGO. So in that sense, this app offers a way of addressing a health issue whether it's mental health or, for example, infectious diseases, outbreaks. We can think of new ways of how an app would be appropriate for that. But what this also shows is that collaboration between, and that's what we are all here for, different stakeholders, government, private sector, academia, and the public, NGOs, CSOs, is extremely key in creating innovations, but also scaling them, and that's where private sector comes in. Now, I have pestered already some of you about the triple helix model, or quadruple helix model, when the public comes in. And I think this is important because with AMREF and AMU, the university, we're writing a white paper on how we are approaching this new kind of collaboration on global health security, which we will feed into the AHIC conference in the early March. As mentioned yesterday during the dinner, there will be some global health security talks. So if I reach out, please be acceptable, and I can ask you a few questions about that to become inspired. To come back and to conclude, I think that innovation, when it comes to not only interventions, building trust, but also the feedback mechanisms, is in the digital space. Not forgetting that, of course, there's people who are not familiar with the digital space, but social media, apps, and these kind of technologies should and are going to help us in addressing outbreaks in a better and more informed way. Thanks.
All right, let's give a round of applause.
I don't want to end this without something that burns my spirit. Art and culture. Art and culture as a means of communication really needs to be stepped up. So we need to sing and dance and give messages as you do so.
What a way to end this. Let's appreciate the panelists. So as I invite Laban, I will also invite the panelists to take to the front for a brief photo session before we allow other programs to proceed. So thank you all for the great participation, and I would also ask all of us, let's do another round of applause to the audience. I think we've had one of the most amazing discussions today. Thank you, and thank you very much.
Thank you very much as well, Eric. Much appreciated. Okay, maybe come through. I'll follow the cue from the photographer. Building trust and health literacy, the role of risk communication, community engagement in health, emergency preparedness, and response. Ladies and gentlemen, that marks the end of our third panel for day 3. So please give a round of applause as well to them as they exit the stage. And rightfully mentioned as well during dinner last night is that, there's been a lot of conversation out there of what is really happening here in Mombasa, and particularly in this very room. I would want that to sort of build momentum into the communique or to the Mombasa Declaration. And I urge us all to start thinking about that even as we break for lunch and go into a breakout session and we come back for our closing ceremony. So just to give you a teaser into really what's the conversation has been, please train your eyes on the screen. This has actually been shared by the Office of the 4th President, kind of a highlight of what transpired yesterday. Thank you very much. Yeah, give a round of applause, to be honest. I think that's a message that has been out there. I'm told yesterday we were on CNN, and very soon I think we'll be on Washington Post, if I'm not wrong. I think Nzaish will confirm that as well. But be as it may, I think the conversation continues. There's a lot out there that's happening. There's a lot of buzz being created by this summit. So thanks to you, the delegates. Thanks to you for creating time. And I really want to appreciate all the conveners as well for making this happen. And we can't wait for the Mombasa Declaration that will come up. Ladies and gentlemen, without further ado, and before we break for lunch, allow me to call on stage Della Davis and James Lolo, who's from the University of Nebraska. They have an appreciation to make, so we'll give them that.
Thank you. We, from the University of Nebraska Medical Center, wanted to recognize that this is an interstate symposium and that there are several countries represented here. So we're going to be calling on the senior leaders from each of the countries represented here to recognize and give you a gift from us, from the University of Nebraska. So I'm going to have Vicky just give me the list of the names, and we'll call you up. And just to tell you what we're giving you, we're going to give you a Nebraska mug from Global Center for Health Security labeled. A special isolation and quarantine manual from Nebraska, all from our faculty that you could use for your local purposes. And then I'm going to have Dr. Lawler, who's also a colonel in the Navy, to explain what this coin represents. I want you to explain this.
Thank you. Sorry. So we also want to hand out a coin from our Global Center for Health Security. It has our university logo on the front, and then logo of our Global Center for Health Security on the back with a globe and a biohazard sign. These coins are things that in the US institutions often give out to show appreciation for a job well done. It actually comes from military tradition. So military units initially developed these because when their personnel were coming back from patrols to the front lines, sometimes the enemy was stealing code words, and so they couldn't count on just somebody giving the right word to show that they were a member of the unit, so they handed out these coins to every member of the unit, so the member would show the coin to the guard to prove that they were a member of the team. So these coins, when we give them out to you, they indicate that you are now a member of our team, as we are all members of the same team in health security, working together to create a safer planet. I wish I had coins for all of you here because, as I said, you all are members of our team, but please symbolically, from your country representative, know that this goes to you as well, and we're greatly appreciative of everyone here and all the work that's been done, and more importantly, the work that's yet to come after the summit.
So we're going to start with our colleague from the World Health Organization, Dr. Kasola. Please come up. So James, yeah, you give the coins. I'll give the phone. Come on up.
And the way we give a coin is through a handshake. So I have the coin in my hand and we pass it on a handshake. So thank you very much. Also, I'll remind everyone that tradition is that everybody in the team carries the coin with them. So if we're at a bar and we all put our coin on the bar and you don't have your coin, that means you pay.
Okay, thank you. Okay, Director of the Africa CDC, please come up. Region? Regional office. Lucy. Thank you so much for all your contributions and your engagement throughout this whole session. So here you go. Coin. Okay, stand right here. We'll have a minister from the Comoros, please join us. Il n'y a pas de quoi. Burkina Faso. There she is. Thank you, Madam. Dr. Matende Chera, please come up from Kenya.
Thank you very much.
From Mauritius? There she comes. Do I sing? South Sudan, Harriet Akello.
Thank you. Thank you.
Okay, I have to ask for forgiveness in advance. Republic of Madagascar, Rakotohalvalona. Did I get that right? At least he knows who he is, which is good. How did I do? Was I close? Oh, Dr. Revo, okay. Republic of Zanzibar, Mr. Fadili? Oh, there he is, okay. Okay. Last but not least. Thank you. Well, once again, thank you all so much for this collaboration. We are actually so honored to be a part of this. And as we wrap up, we just want to again say thank you for taking the time to join us. And we hope to see you at the next one. Take care.
There's an afternoon session.
Oh, yeah, of course, we're not done yet. We still have an afternoon session.
We want to say thank you as well. Thank you, Chancellor. Appreciate it. Please give a round of applause to the University of Nebraska team as well, an entire team. Thank you as well for the appreciation. At this point in time, I'd like to invite on stage really quick. We just have the last breakout session, good people. Can we all finish strong? Yeah, can we finish strong? Promise? Very well. So we have the breakout session that is looking at training and workforce development in health security. May I please have on stage a representative to Professor Tamari Rotich, who will be moderating this session. And also we'll be having this session on regulatory and policy alignment for health emergency preparedness by Dr. Sarah Muteru. I think I saw her in the room. Please come up on stage. That will be at Shimba room. The one on training workforce will be right here at the ballroom. And last but not least, we'll have the role of military and law enforcement security services in preparedness and response at Dodori. This will be moderated by James. So, goodness, James, please, and I'm happy that you actually spoke about the military honors and So really quick, yeah, these are the moderators for the afternoon. May I please have a representative from AMREF who will be representing Prof. Tamari? Check. So this is just a teaser into what to expect. It's just about 1 o'clock. They will just give a teaser into the panel. We break out for lunch, go for the panel presentation for 45 minutes. So that's 2 to 2:45. Let's be back here by 3 p.m. for the closing ceremony, please. Who wants to go first?
Yeah, good afternoon, everyone. Yeah, I know it's it's lunchtime. My name is Dr. Sarah Muteru. I'm the General Manager, Regulatory Affairs, Product Quality and Safety at the Kenya Biovacs Institute. I will have the privilege of moderating a session on how we'll actually discuss the alignment of regulatory and policies and just laying the foundation, because from our 3-day discussions we've seen, for us to safeguard public health, we have to make sure that the foundation is strong enough, and we need the regulations and also the policies to be robust enough for us to respond to health emergencies. So we will have diverse perspectives from Rwanda and also from Kenya. I think the panelists from Uganda will not be present, but all the same, I guess we'll have a good representation for the East African community. Thank you very much. Yes, join us at the Shiba room. Thank you.
Hello again. I'm James Lawler from the Global Center for Health Security at the University of Nebraska Medical Center. You are probably going to be sick of me by the end of the summit today, but I will be hosting the breakout session on the role of military and security forces in health security and responding to health emergencies. So should be an interesting discussion and topic. It is true that many of our military and health security forces do not necessarily have this role front and center in their missions or really in their desires. However, these organizations are often called upon in emergencies because of the unique capabilities they have in logistics and communication. And so inevitably those organizations end up being involved for better and sometimes for worse as well. So we'll talk about all of those issues. How do we better align those military and security forces with the other civilian response entities? How do we make sure that we maintain transparency, that we respect equity, that we're aware of human rights concerns? And how do we ultimately create better preparedness and response using these entities to the best of our ability? Thanks. Oh, we're in Dodori, I think. Is that right? Yes. All right, time's up.
Okay, good afternoon. So in our panel discussion, we are going to have a candid talk on training and workforce development in health security, and I'll be flanked by Alida, Ravera, Doreen, Sospita, and Martin. And this is where now we are going to really have a lot of input on how to train the workforce that will be able to be the frontline workers in global health security. So we will be in the ballroom, and all are invited. Thank you very much.
That's it, ladies and gentlemen. You have the 3 moderators. So please see you at 2 p.m. for the start of the breakout session, and then let's all gather back here by 2:45, latest 3 p.m. for our closing ceremony. Enjoy your lunch.